Acute tubular necrosis ATN is an kidney disorder. Look at this picture shows that kidney and ultrasound findings. Look at this and CT MRI findings. A detail going on. Introduction. Acute tubular necrosis ATN is one of the most common cause of acute kidney injury AKI. It occurs due to damage to the renal tubular cells, which results in the inability of the kidney to filter waste, regulate fluids, and maintain electrolyte balance. ATN is often reversible if diagnosed and managed promptly. A definition. Acute tubular necrosis is a condition characterized by the death and destruction of renal tubular epithelial cells, leading to acute kidney injury. It is usually caused by ischemia or nephrotoxic agents. Etymology. The term acute tubular necrosis derives from Latin and Greek root acutus, Latin for sharp or severe, tubulus, Latin for small tube, referring to kidney tubules, and necrosis, Greek necrosis meaning death of tissue. It describes a condition where the renal tubular cells undergo sudden injury and necrosis, often due to ischemia or toxins. Types. 1. Ischemic ATN caused by reduced blood flow to the kidneys, leading to hypoxia and damage to tubular cells. 2. Nephrotoxic ATN caused by exposure to toxic substances such as drugs, contrast media, heavy metals, or myoglobin from muscle breakdown. Causes. 1. Ischemic causes hypotension, shock, sepsis, severe dehydration, burns, hemorrhage, cardiac failure. 2. Nephrotoxic causes antibiotics such as aminoglycosides, amphotericin B, radiocontrast agents. chemotherapy drugs, heavy metals, lead, mercury, hemoglobinuria, myoglobinuria, toxins such as ethylene glycol, pesticides. Risk factors: 1. Chronic kidney disease CKD. 2. Diabetes mellitus. 3. Hypertension. 4. Older age. 5. Severe infections sepsis. 6. Prolonged surgery or anesthesia. 7. Use of nephrotoxic drugs. 8. Hypovolemia or dehydration. Complications: 1. Fluid overload and pulmonary edema. 2. Electrolyte imbalances. 3. Uremia leading to encephalopathy. 4. Chronic kidney disease if not properly treated. 5. Multi-organ failure in severe cases. Pathophysiology. Step-by-step pathophysiology of acute tubular necrosis. 1. Initiating injury. ATN is triggered by ischemia or nephrotoxins. Ischemia leads to hypoxia while toxins directly damage tubular cells. 2. Endothelial dysfunction and reduced blood flow. Ischemia disturbs endothelial cells, leading to reduced nitric oxide production. This causes vasoconstriction, worsening hypoxia, and further decreasing renal perfusion. 3. Tubular cell injury, swelling. Prolonged ischemia or toxin exposure causes tubular epithelial cell damage, cells walls loss polarity, and death from basement membrane. 4. Cell death and debris formation. Injured cells undergo apoptosis, programmed cell death, necrosis, uncontrolled death. Necrotic cells and debris accumulate in the tubular lumen, forming cyst. 5. Tubular obstruction and filtration decline. Cyst and cellular debris block tubules, increasing intratubular pressure. This leads to reduced glomerular filtration rate and oliguria, low urine output. 6. Back leaks of filtrate. Damaged tubules loss integrity, allowing filtrate to leak back to circulation. This further decreases effective urine output. 7. Inflammation and further injury. Damaged cells release inflammatory mediators, recruiting immune cells. Inflammation exacerbates tubular injury and delays recovery. 8. Recovery phase, if reversible. Severely epithelial cells proliferate and regenerate the tubules. Normal renal function may gradually return over day to week. If severe or prolonged, ATN can lead to chronic kidney disease or irreversible renal failure. Signs and symptoms. 1. Oliguria, low urine output, or anuria. 2. Fluid retention, edema, pulmonary congestion. 3. Electrolyte imbalance, hyperkalemia, metabolic acidosis. 4. Nausea and vomiting. 5. Fatigue, confusion, seizures. 6. Uremic symptoms. Diagnosis. A. Laboratory tests. 1. Serum creatinine elevated. 2. Blood urea nitrogen BUN elevated. 3. Serum electrolytes, hyperkalemia, acidosis. 4. Urinalysis. B. Imaging. 1. Renal ultrasound to rule out obstruction. 2. CT scan for structural abnormalities. C. Biopsy, rarely needed unless the cause is uncertain. Nursing diagnosis. 1. Fluid volume excess related to renal dysfunction. 2. risk for electrolyte imbalance related to impaired kidney function. 3. Impaired urinary elimination related to tubular cell necrosis. 4. Anxiety related to the severity of illness and hospitalization. 5. Knowledge deficit regarding condition and treatment plan. Disease management. First, medical management. 1. Identify and treat the underlying causes. 2. Fluid management. IV fluids, diuretics. 3. Electrolyte correction, hyperkalemia, calcium gluminate, insulin based glucose, sodium bicarbonate, dialysis if severe. Metabolic acidosis, sodium bicarbonate therapy. 4. Dialysis indicated in cases of severe fluid overload, refractory hyperkalemia, severe acidosis, or uremic symptoms. Nursing management. 1. Monitor vital signs and urine output hourly if necessary. 2. Assesses fluid and electrolyte balance. 3. Strict intake and output monitoring. 4. Administer medications as prescribed. Diuretics, electrolyte replacements, bicarbonate therapy. 5. Prevent complications, infection, skin breakdown, nutritional deficiencies. 6. Educate patients and caregivers about ATN, prevention and lifestyle modification. Treatment options. 1. Supportive care, hydration, electrolyte management, monitoring. 2. Pharmacological therapy, diuretics, bicarbonate, vasopressors if needed. 3. Renal replacement therapy, dialysis in severe cases. 4. Avoidance of nephrotoxic drugs. 5. Nutritional support, low potassium, phosphorus, and moderate protein diet. Psychosocial medicine. 1. Patient education, providing knowledge on disease, treatment, and lifestyle changes. 2. Emotional support, counseling and reassurance to reduce anxiety and depression. 3. Family involvement, engaging family members in the care process. 4. Support groups, connecting patients with others experiencing kidney disease. 5. Spiritual support, encouraging faith-based coping mechanisms for interested patients. Prevention 1. Hydration. Maintain adequate fluid intake, especially before contrast, imaging or surgery, to avoid nephrotoxic drugs. Monitor drug levels and use alternatives when possible. 3. Manage chronic conditions, control hypertension, diabetes, and cardiovascular diseases. 4. Early recognition and treatment of conditions that may lead to ATN. Example, sepsis, dehydration. 5. Monitor high-risk patients closely in hospital setting. Conclusion. Acute tubular necrosis ATN is a common cause of acute kidney injury, often resulting from ischemia or nephrotoxic substances. Early diagnosis and prompt management can significantly improve outcomes. Preventive measures, proper medical and nursing care, and patient education play crucial roles in reducing the incidence and severity of ATN. Thank you. Have a nice day.